I'm David Devine, and it's a privilege to be here. This is my third health summit, and it's an honor to be presenting today. What I'm going to be doing today is presenting a case study, and in mental health and addictions, we tend to value case studies as a way of showing what we're doing in the field and what's working, what's not working. A couple of things I'm interested in exploring are questions of what is the effect of having an out therapist, an out medical healthcare provider? How does that impact somebody who is unsure of their sexual orientation or in the closet? So I'm presenting this gentleman who I saw back in January. He presented as a Caucasian male in his mid-30s, recently separated from his wife. He had a history of cocaine and alcohol abuse since his late teens, and he also had a diagnosis of bipolar 2. Bipolar 2 is one of the areas of bipolar spectrum where you see sharp increases of what we call hypomania, which is elevated expansive mood, oftentimes accompanied by delusional or grandiose thinking. But it differs from bipolar 1, where you have mania, which can delve into psychosis, psychotic thinking, and can actually last a bit longer. Bipolar disorder also has a depressive feature, obviously, and depression can be just as deep as the mania or hypomania is high. He had been working for a multinational company and was in a very high-level executive job up until 2012, when he was arrested during an incident in which he was experiencing a hypomanic phase, plus he was on cocaine and alcohol. And I should add that people who have struggled with both bipolar disorder and substance abuse tend to take substances that enhance their mood state, typically maintaining a manic or hypomanic phase. So he had actually been aware of his same-sex attraction from an early age. His first experience was with another male, also age 15. They had frequent sexual encounters together, as well as with women. But apart from this one friend, he primarily focused on engaging in sexual activities with women. But they were usually very superficial, short-lived, and the only one that really stuck was the one that he had with his wife. And even during marriage, he would do things like masturbate to gay porn, and oftentimes he would be doing this while using cocaine. Oftentimes his wife would catch him, and he would deny that what he was doing. One of the areas, though, is he never felt safe talking about or acknowledging his same-sex attraction or possible bisexuality until he was seen by me. So I'm going to talk briefly about syndemics and the minority stress model as it applies to this client and how I conceptualize both gay men, mental health, and addictions. So I first learned about the minority stress model, which was presented by Dr. Trevor Hart in our Beyond Behaviors workshop earlier this year. And it's a fairly straightforward model. Heterosexual men, life stressors, personal stressors. But with gay men, we experience stigma, internalized stigma plus external stigma, along with our life stressors and personal stressors, and thereby experience poor health outcomes. So even though we experience both internal and external negative events, and I piggyback this on the Sex Now study, calm down, in which we find that people who are not out of the closet fare worse in their health outcomes than those of us who are out of the closet, both at work, in our personal lives, and our families. So this is what I conceptualized for the client. He had a trifecta of stigma here. We had mental illness stigma, he had addiction stigma, and the stigma of being a closeted gay bi man, along with life stressors and personal stressors. And this culminated in the event that occurred last year with his arrest, and also multiple hospitalizations, not only for his bipolar disorder, but also for addictions. As I said earlier, he reported being aware since his mid-teens that he was attracted to both men and women. However, he also reported that he felt tremendous pressure to follow, in his words, the standard life plan. A wife, 2.5 children, house with a white picket fence, a good job with a good salary. I think that's the life outcomes discussion we're having today, right? He felt very, very, a lot of pressure to be the stereotypical white Canadian young male heterosexual. So he got married to a woman from a wealthy family. He described the marriage as being more of a business relationship than having much love or affection attached to it. He rose rapidly through the ranks of the company, landing a high-level executive position with a multinational firm. So he was doing all the right things if he was straight, but he wasn't. Okay. So while he was married, he would find himself sneaking off to buy cocaine, engage in non-safe sexual practices with other men. Typically during a hypomanic phase, he would turn to cocaine, where he would use and masturbate to gay porn. Though he would still have sex with his wife, he described the sex as being fairly routine, pleasurable, but unfulfilling. I was just following the script and doing what was expected of me. His first hospitalization was in the mid-2000s when he was finally diagnosed with bipolar II. Though we received a lot of support, both from the mental health side and the medical side, with counseling and all sorts of treatment, he never disclosed his same-sex attraction and never dealt with it. He reported that he was, quote, in deep denial of who I was. I knew I liked men. I knew that this was part of me. I didn't feel comfortable with and could only act on it with the help of drugs. Even when my wife would call me on it, even after the umpteenth time she would catch me on coke watching gay porn, I deny everything. This is not the mayor of Toronto. I just wanted to refer. Just in case your thoughts were coming in there, like, no. So he began treatment with us in January 2013. Sorry, that was not Toronto bashing, don't worry. So he began treatment with us in January 2013. It was around the second week. He was given something called the Outcome Questionnaire. The Outcome Questionnaire is something I've used in private practice. It's something I've rolled out at the clinic. In fact, I'm running an outcome study using the Outcome Questionnaire. It's a 40-item self-report outcome tracking measurement instrument. It's designed to be used at the first session or pre-treatment, during treatment, after treatment. It's a very well-researched outcome measure. It was developed to measure patients' progress in therapy. It's also designed to be repeatedly administered throughout treatment. And it looks at 3 domains. First, it looks at symptom distress, essentially asking questions about, do you feel blue? Do you feel sad? Are you feeling anxious? Do you need to have a drink in the morning when you wake up to avoid a hangover? Interpersonal relations. Do you get along with people? Are you happy with your relationship? Is your sex life okay? And social role. Are you happy in your job? Are you having arguments in your job? Are you doing okay in school and vocational stuff? And we look at pre-treatment and post-treatment differences as well as monitoring ongoing treatment response. So I'm looking to see what those numbers are, both in the individual domains, but also the total score. And really one of the useful things is we can use this for other decision-making tools within the healthcare system. So we can look at the overall score and focus on that. Depending upon which domain the client scores the highest at, we can focus on a specific domain because that may be where the trouble is. And we can see how the numbers fluctuate. And I'll give an example. I'll show you what we're looking for in terms of number fluctuation. The important thing to note is that it's not a diagnostic tool. It can inform some diagnostic decisions, such as suicidality, such as feeling blue always, frequently, feeling anxious, having unpleasant thoughts in your head, and that could lead the therapist to ask questions, but it is not a diagnostic tool. Okay. So his was one of the highest scores I've ever seen. It was 124. It was remarkable because he did not endorse any suicidal ideation, but he did endorse a lot of symptom distress. His score was, and the total score cutoff is 65. So if you're scoring below 65, you're probably doing pretty well. His symptom distress level was 75. It was pretty much a whole column of 4s. 4 is the highest you can score. Interpersonal relationship was 37, cutoff is 15. Social role was 12, cutoff was 15. I do note that he had just come out of the hospital. He didn't have a job. He wasn't engaged in education or even treatment. So that the social role thing is, you need to kind of take that with a certain lens. Okay. So he started our groups. We have 2 program streams. We have an outpatient program stream and a day program. Our outpatient is a mixture of drop-in groups, which you can show up to whenever you can, plus groups that you register for and you make a time commitment for. Our day program is an intensive 8-week program that goes from Monday to Friday in the afternoons. He had expressed occasionally interest in going to the day program, but he maintained just staying in the outpatient. So the groups he went to focused on addictions and recovery issues, mindfulness-based relapse prevention and recovery, CBT skills, cognitive behavioral therapy, challenging negative thoughts, challenging automatic negative beliefs, and stress management. None of these groups really deal with sexual orientation. In fact, our groups mainly deal with addictions issues more than mental health. But he would also attended individual psychotherapy with me on a weekly basis. And this is where we really dug deep into sexual orientation, into his sexual history, into internalized homophobia. He didn't think he had internalized homophobia. He grew up in a very liberal, progressive family, a very queer positive family and friends. He never felt that. He always felt that if he came out today, he would be accepted. But going back to the life goals approach, is he got a lot of it from the external world, not necessarily the family. A gay man is not an executive. A gay man isn't married. A gay man does thus and such, and that he's not thus and such. So we really plumbed the depths of his internalized homophobia. His fears about coming out, which he at one level felt were unfounded because he knew he'd be welcomed, but he had that larger societal constraint and construct of what it means to be a gay man or a bi man. And he also said, I have no idea if I'm really gay. I have no idea if I can be a gay man because I've only had gay sex or done gay porn when I've been high. And so that was an interesting question. We're going to ask that. And we also worked very hard on bipolar disorder using interpersonal social rhythm therapy, which is a very well-researched and documented therapeutic technique that really gets into symptom management, symptom recognition, how your life impacts your symptoms, either depression or hypomania, and also medication adherence. That was a big key. So I encouraged him to go to the GLBT 12-step meetings. There are a couple at Community. I encouraged him to go to HIM programs. And I gave him bibliotherapy, which is probably one of the easiest forms of psychotherapy available. Here's this great book, go read it, see ya. Come back next week. But really specifically addressing bisexuality, coming out, gay men leaving heterosexual marriages, gave him The Velvet Rage, which is a really good book on addictions and on being gay. So I kept administering the OQ, and this is what we're looking for. I'm looking for the cutoff, again, for symptom distress is 36, and I'm looking for a 10-point switch. So I want either 10 points lower, but 10 points higher or 10 points lower than his original score is indicative of change. Interpersonal relationship, the score is below 15, cutoff is 15, and it suggests that the patient is experiencing a level of satisfaction in relationships equivalent to normal functioning. Reliable change is considered to occur after 8 points change. So we're looking for 8 points. Okay. And social role, again, we're looking for a 7-point change and a 14-point change in total score. I got it. All right, so after 1 month of treatment, so this is February, his scores went down. It went down from 75 to 60. Reliable changes, 10-point shift. Score. Interplational IR went from 37 to 30. Reliable changes, 8-point shift. Okay, not so much, but pretty close. And the totals and his SR remained the same. OQ total went from 124 to 102. Reliable change again is a 14-point shift. This was good. This was huge in 1 month. He engaged in 12-step groups. He made friends with gay guys. He was able to, as he put it, what he really said was, I was able to walk down Davie Street, check out a guy's ass, and look at my friend and go, cute ass, huh? My friend would go, yeah. And he said that was so liberating just to be able to do that. He found that he could enjoy gay porn without the use of drugs. I actually told him, go home. Don't do it here in my office, but go home and turn on some gay porn. You're sober, you've been sober for a couple months now, turn on some gay porn, see what happens. Everything worked. Late summer 2013, he entered his first same-sex relationship. I tried not to be jealous, and found he could enjoy intimacy with another man without drugs and without shame and without guilt. And then he returned to work in 2013. So he continued improvement. In June of 2013, he was at cutoff or below. And the latest OQ that I administered was about 3 weeks ago, and this is what we see here. His OQ total is 31. I'm not sure I would score that well, or how any of us would. And to me, this speaks a lot to, we tend to separate mental health and addiction and sexual orientation from addiction and mental health. I think when we address something as powerful as your identity as a sexual being, in this case as a sexual man, and who and what you really are, it's not to say he didn't have urges and cravings, but he was able to handle those urges and cravings, and they were not as big, because he was no longer hiding this secret. He was no longer having this shame and guilt. And he was able to learn how to act on his attraction to other men in a healthier way. Now, I wanted to include a picture of my door in my office. I had, up till about 2 weeks ago, and it was stolen, the anti-homophobia poster of the two hockey players going in for a kiss. It was my favorite poster. It was there for 3 weeks, 3 months, 3 years, and it got stolen a couple weeks ago. I also have a pride flag on my door. I have a pride flag in my office. I am completely out as a gay man at work. And when he came down to sit with me, he knew he was in a very safe space. And I asked him one time, would you have told me about your same-sex activities if you didn't know I was gay? And he said, no, I don't know if I would. I don't think I would. And a week doesn't go by that I don't have a client coming at my door saying, David, I need to talk to you. And I know that look in their eye. It's, I'm gay, I haven't told anyone, can we have a session? And I say, sure, of course, no problem. So I think one of my questions, two of my questions are, one thing, the heteronormative pressure put on men and women, but men, to act and be straight and sublimate your true feelings. We haven't seemed to gotten past that, and I think that's an interesting question. How much are we seeing in the mental health world, in the addictions world, is because people are not being true to themselves and being truly who they are. I've seen that people who are later in recovery, I say, go be yourself, and they say, I have no idea who that is. And that's straight, gay, bi, whatever. I think also it's important for healthcare providers to feel comfortable to be out. Because when the healthcare provider is out and there's a queer positive vibe, if you will, in the healthcare setting, that makes it a lot easier and a lot safer for the clients or patients who are struggling to feel safe, to say, I need to talk to you. I'm gay. I look forward to questions. Thank you all very much.